Hello friends, so what we are going to discuss today is one of the very interesting and logical concept of knee orthopedics, that is the idea of patellar dislocation. So what our plan for today is we are going to understand the concept of acute patellar dislocation, the concept of recurrent patellar dislocation. We are going to understand the etiopathogenesis, the causative factors of recurrent patellar dislocation. We are going to understand how do we reduce a case of acute patellar dislocation in casualty. We are going to understand the most important part. We are going to understand the radiological evaluation of the etiopathogenesis of recurrent patellar dislocation, the most important part of trochlear dysplasia. And at the end, what we are going to discuss is about the surgical and the management of recurrent patellar dislocation in brief at the end. So without further ado, let us begin with the idea of acute patellar dislocation. So most commonly patella is dislocated laterally. Right, the cases of acute patellar dislocation in casualty occurs in adolescent age group most commonly, that is 10 to 17 years of age. Right, so the most important part, whenever you get a case of acute lateral patellar dislocation, the lateral dislocation is the most common. You are suspecting is a tear, complete or partial tear of the medial patellofemoral ligament. You are suspecting a tear of medial patellofemoral ligament. Most commonly it is from the femoral origin, less commonly mid substance, least commonly patellar origin. So most commonly the medial patellofemoral ligament tear is at the femoral origin. Now a case of patellar dislocation, when do you get a warning sign? When it demands a operative fixation, whenever there is a large osteochondral fragment or the osteochondral fracture. Now the second question which should come to your mind is, from where do we get the osteochondral fragment? Most commonly we get the osteochondral fragment from the inframedial edge of the patella. So whenever we get a large osteochondral fragment, clinically most probably you find a hemarthrosis. So whenever you get a hemarthrosis, the suspicion should come in your mind that there might be osteochondral fragment which might require operative fixation. We are going to discuss in detail. These are some of the important points to discuss at the beginning. Now, how do we get the x-rays done to confirm the diagnosis of lateral dislocation and look for the osteochondral fragment? Now, how does a case of acute and recurrent patellar dislocation presents to your EMD casualty or your OPD room, right? So most important, the patella is dislocated laterally. And tenderness is present medially. At the location of medial patellofemoral ligament tear. Right. So usually the tenderness is present the medial border of patella corresponding to the MPFL tear. Now, whenever a patient of recurrent patellar dislocation comes to the OPD, you check for two things: patellar apprehension test. You try to dislocate the patella, sublux the patella laterally, and there is some apprehension. And additionally, when you examine the patella, there is abnormal excessive passive lateral displacement of patella. You compare it with normal side, right? So there is abnormal excessive passive lateral displacement of patella. Now, in acute cases, you usually find effusion and hemarthrosis. So whenever there is hemarthrosis present, you have to give a suspicion. Of a osteochondral fracture or a fragment in the joint, right? Not to miss the diagnosis. Now, there are few specific findings in a case of recurrent cases, right, which needs to be evaluated, right? So whenever there is genu valgum or external tibial torsion, or there is high riding patella alta, whenever there is genu recurvatum or torsional deformity of femur and tibia, these patients are more prone to recurrent patellar dislocation. So whenever a patient with a history of patellar dislocation presents to the OPD room, you need to evaluate for these factors. Additionally, for trochlear dysplasia, these factors need to be evaluated. We are going to discuss in detail in the radiological evaluation, right? Additionally, one important sign which you observe in cases of recurrent patellar dislocation is the JS sign or the inverted J sign, that is the maltracking of patella. So whenever the patient extends the knee from the flexion position the patella goes in this fashion. So whenever the patient is kept the knee in flexion, and whenever the patient extends, the patella goes laterally, forming the inverted J sign, forming in the inverted J fashion, right? So that is why this sign is called the J sign, right? So in the later stage you also find patellar degeneration. So you might also find subpatellar crepitus once the degeneration sets in. Now the next concept, why does the patellar dislocation occurs? Because of the tightening of the lateral structures and the loosening of the medial structures, which leads to the lateral subluxation, lateral dislocation of the patella. So in cases of recurrent patellar dislocation, you observe that there is a finding that there is atrophy of the medial structures, quadriceps and VMO, while at the same time there is iliotibial band contracture. So the lateral aspect is in more tightness, iliotibial band contracture, or you might find abnormal IT band attachment, which limits the knee flexion. So these are some of the specific findings you see in cases of acute or recurrent patellar dislocation, right? Now what we are going to understand is one of the important aspect of etiopathogenesis of recurrent patellar dislocation. What are the predisposing factors? The most important, everyone knows, if there is a multiple history or previous history of patellar dislocation, if there is some ligamentous laxity. Now this is a syndrome which predisposes to patellar dislocation very often, that is miserable malalignment syndrome, when there is excessive external tibial torsion, excessive femoral anteversion and genuvalgum. All these three classical findings predispose to a recurrent patellar dislocation. Now some of the anatomical factors like osseous factors, whenever there is patella alta, the length of patellar tendon is more than the patella, we are going to discuss the ratio, it predisposes to recurrent dislocation. Next is the most important cause of patellar dislocation, that is trochlear dysplasia. Whenever you plan for an operative fixation of recurrent patellar dislocation, the first thing you need to evaluate is the trochlear dysplasia, and you need to realign the trochlea before fixing the even if you fix the osteochondral fragment or repair the MPFL. If there is a trochlear dysplasia, your surgery is a failed surgery. It is a nightmare. You need to evaluate the trochlear dysplasia, right? Additionally, there are chances that lateral femoral condyle hypoplasia is there, which predisposes to patellar dislocation. Now muscular structures, what happens is the medial, as I discussed, the medial aspect is loose, the lateral aspect is tight, in common words. So whenever there is dysplastic VMO or quadriceps, an overpull of iliotibial band or vastus lateralis, all these factors predispose to a case of recurrent patellar dislocation, right? So whenever a case comes to you, you need to evaluate all these factors. Now we are going to understand a very logical concept. Whenever a patient of acute patellar dislocation presents to the casualty, how does the patient present? The patient presents with inability to extend the knee. There is apprehension while extending the knee, right? On examination, the patella has been laterally subluxed. On X-ray, you can confirm the diagnosis. The patient is in pain and is kept the knees in flexion. How do you manage the patient in casualty? Right? How do you manage the patient in casualty? After that, we'll evaluate. First and foremost, after confirming it on X-rays, we need to reduce the patellar dislocation. So how do you manage a case of patellar dislocation in EMD? What do we do? First things first, we need to flex the knee. Why do we need to flex the knee? We need to relax the quadriceps. We need to relax the extensor mechanism. After flexing the hip, what do? We gradually extend the knee. With one hand, with some pressure applied to the lateral margin of patella, trying to medialize the patella. Both these things has to go hand in hand. Gradual extension of the flex knee with keeping the hip flexed to relax the quadriceps, and the pressure is applied lateral to medial to relocate the patella, right, which has been laterally subluxed, right? Usually patellar dislocation reduces easily in EMD with this maneuver, keeping all these three things in mind. Once the reduction is confirmed, the routine management, if it is not complicated, right, with osteochondral fragment, hemarthrosis and all those complicated factors, we are going to discuss it. Right, so the usual management is we give extension brace and cast for 3 to 6 weeks. We don't allow the patient to flex the knee immediately, but yes, we can start immediate full weight bear walking as tolerated with crutches. Right, so once the patient is comfortable walking, we give patella stabilizing brace, and we gradually start the ROM of knee. 10 degrees, 20 degrees, we gradually start increasingly permitted. The ROM is gradually increasingly permitted over 3 to 4 weeks with passive ROM exercises. Right, and once the full passive ROM has been achieved, there is no effusion, no hemarthrosis. Clinically, the knee is totally normal. And once the quad strength is achieved 80% of the opposite side, the patient can return back to its normal routine. But this is a case of uncomplicated patellar dislocation with no fracture, no hemarthrosis. Whenever it is complicated with some other factors like tear, ligament tear, and osteochondral fragment, how do we ideally go about a case of acute patellar dislocation? That is what we are going to discuss with a flowchart method. So whenever you get a patellar dislocation acute case, you confirm it on x-rays. On x-rays, you check for a displaced osteochondral fragment. Right, if let's suppose if the displaced osteochondral fragment is not visible on x-rays, it is not visible on x-rays, right? But so then you check for hemarthrosis. So whenever hemarthrosis is present, you have to raise a suspicion of a osteochondral fragment. You should not rule out the osteochondral fragment, right? So if there is significant hemarthrosis present, you reduce the patella, you give extension brace, and once the swelling subsides, you go for MRI to see for the articular surfaces, to see for osteochondral fragments, for displaced osteochondral fragment. And if the osteochondral fragment is present, you need to go for operative fixation of fragment with repair or reconstruction of the medial patellofemoral ligament. Now, if there is no osteochondral fragment on X-ray, there is no clinical hemarthrosis, you follow the protocol we discussed in the previous slide. You go for immobilization and extension for 3 to 6 weeks. You go for knee rehabilitation and routine activities. And on the follow-up, if there is some history or examination of loose bodies, and if there are symptoms of loose bodies present, you need to evaluate it again. And if there are small fragments present, you need to remove the fragment. But if there are no symptoms, no signs in further evaluation, you do not find any loose bodies, you continue the knee rehabilitation and return to the normal activity as we discussed in the previous slide. So this was the case when there are no osteochondral fragments visible on the X-ray. Now, if the osteochondral fragment are visible on the X-ray, clear cut on the X-ray itself, you find a visible displaced osteochondral fragment, you need to go for operative fixation of the fragment. You need to go for operative fixation of the fragment along with repair or reconstruction of the medial patellofemoral ligament or the other ligaments which are injured or damaged. But the catch lies herein. You need to evaluate before going for any operative fixation in the recurrent patellar dislocation. You need to evaluate for the etiopathogenesis, the causative factor. If there is some trochlear dysplasia, if there is some genu valgum, if there is some patella alta, if there are some osseous or other etiopathogenic factors which we discussed in the second slide, if they are present, you need to address them before fixing the fragment or repairing the ligament, right? So whenever the distance, this distance is important, we are going to discuss in radiological evaluation, the distance between trochlear groove and tibial tuberosity, if it is more than 20 mm, if there is patella alta, if there is trochlear dysplasia, any of these are present, right? So you need to remove the fragment, but additionally you need to go for distal realignment procedures. We are going to discuss in brief at the end some of the important distal realignment and deformity correction procedures and surgeries, right? And if there is no such significant associated factors, you directly go for removal of fragment or fixation of the fragment depending upon the evaluation. Along with that, you go for repair and reconstruction of the MPFL, right? So when do we go for repair and when do we go for reconstruction of the MPFL ligament? So whenever the lesion is at the end, right, at the femoral end or the patellar end, whenever the tear is at the femoral or patellar origin and ligament is intact otherwise, you go for a direct repair. But whenever there is a combined tear and the quality of ligament is poor, you go for a reconstruction of the MPFL ligament. Right? So next we are going to discuss is when do we go for early surgery after acute episode of patellar dislocation. What are the indications? So whenever there is significant concurrent osteochondral injury, we go for operative fixation early. Whenever there is palpable disruption of medial patello-femoral ligament, VMO and adductor mechanism, the whole extensor mechanism has been disturbed, especially whenever there is palpable disruption of the MPFL ligament, you go for a repair or a reconstruction of the MPFL along with the fixation SOS if required. Right? Whenever there is large, complete or avulsion or mid-substance tear of MPFL ligament, whenever there is patellar subluxation on the merchant view, and early failure of non-operative management with subsequent redislocations. These are the indications of early surgery after acute episode of patellar dislocation. Now we are going to understand the most important part of this tutorial, that is the radiological evaluation. Especially in the case of recurrent dislocation, we need to understand the concept, the etiopathogenesis and the causative factors which need to be addressed first before going for operative fixation. Right? So basic x-rays, what do we see in AP view? We check for the Q angle. What is Q angle? It is the angle between two lines, that is from ASIS to the midpoint of patella, that is the first line, and the second line is from the midpoint of patella to the tibial tuberosity. If the angle between, normally the angle in males is 10 degrees and in females it's 15 degrees. If the angle is more than this, as per the sex, if it is more than 10 degrees in males and if it is more than 15 degrees in females, it predisposes to the case of recurrent patellar dislocation. Right? That is what you see in AP view. In lateral view, we need to evaluate for the causative factor, important causating factor, that is the patella alta. Right? And the Blumenstedt's line, the position of the patella. Right? So what is patella? What is the inside salvati index? It is the ratio of the length of the patellar tendon to the patella. So normally it is the ratio of the length of the patellar tendon to patella is between 0.8 to 1.2. If it is more than 1.2, you call it as a patella alta, which predisposes to recurrent patellar dislocation. Right? And normally what is the location of patella? Normally the lower, this is the Blumenstedts line, the intercondylar notch, and we observe in 30 degrees of flexion. So normally the Blumenstedts line, the lower border of patella lies in line of the Blumenstedts line. If there is some change in this, you are suspecting at a etiogenetic factor of recurrent patellar dislocation. Now the third view, which is the most important view in the case of recurrent patellar dislocation, what do you see in the case of sunrise or merchant view? First thing, 3 to 4 important things to be seen in merchant view. First is the lateral patellofemoral angle. Right? So what is the LPFA? It is the angle between lateral patellar facet with the line joining the anterior margin of medial and lateral femoral condyle. Okay, so normally what happens is the patellofemoral angle opens laterally. Normally the patellofemoral angle opens laterally and it is 11 degrees. And whenever if the patellofemoral angle, both the lines of the patellofemoral angle are parallel, or if they open medially, then it is a abnormal patellofemoral angle which predisposes to recurrent patellar dislocation. So in this case, as you can see, the patella has been laterally subluxed and it is opening medially. So whenever the patellofemoral angle, when both the lines are parallel, instead of opening up laterally, if the lines are parallel, or it is opening up medially, then it is abnormal, which leads to case of recurrent patellar dislocation. Right? The second thing, this, as you can see, the patella has been laterally subluxed, and the patellofemoral angle is opening up, medially, then it is an abnormal patellofemoral angle. Right? This is clearly shown in this photo. This is normal patellofemoral angle opening up laterally. If it is parallel or it is opening up medially, that is abnormal. Now the congruence angle. What is congruence angle? It is the angle between two lines, the line bisecting the sulcus angle, the line joining the median ridge of the patella to the deepest point of sulcus. As you can see, the two lines bisecting the sulcus and the line joining the median ridge of the patella to the deepest point of the sulcus. So normally the congruence angle is 6 to 14 degrees. If it is more than 14 degrees, that does mean the patella has been subluxed laterally, so that the line joining median ridge of the patella to the deepest point of sulcus has been lateralized, which increases the angle more than 14 degrees. So this is what you observe in a case of acute recurrent patellar dislocation on the merchant view, right? The next is most important part of the radiological evaluation is you check for the trochlear dysplasia. These needs to be fixed before going for an operative management. This needs to be done in the planning of operating management, right? So normally you see a depression in the trochlear groove. So whenever this depression is lost, whenever there is flattened trochlear groove, this predisposes to recurrent patellar dislocations, right? So whenever there is a flattened trochlear groove, the trochlear groove lies in the same plane as the anterior border of lateral condyle, which is seen on the lateral x-rays classically as the crossing sign. Though there is the depression of the trochlear groove has been lost, leading to the trochlear groove lying in parallel to the anterior border of the lateral femoral condyle. So you can see the classical crossing sign on the lateral x-rays, right? This is the first sign of trochlear dysplasia. The second sign of trochlear dysplasia is the double contour sign. This is very important. So what is double contour sign? So whenever there is medial femoral condyle hypoplasia, or the lateral condyle, in this, as you can see, the lateral condyle, the anterior border of lateral condyle lies much anterior than the anterior border of the medial condyle of the femur. So you get a convex groove. So on the lateral view, if you see, you see a double shadow, because the lateral femoral condyle, as you can see over here, there is some shadow over here. So the lateral femoral condyle line is this. The medial femoral condyle line is this because of the medial femoral hypoplasia. The lateral femoral condyle is more anteriorly on the true lateral view, right? So this shadow which you see over here is the double contour sign, which is the classical sign of trochlear dysplasia, Okay, so this is the double contour sign. Then the third sign you see is the supratrochlear spur, which arises in the proximal aspect of the trochlea. So the three important signs of trochlear dysplasia is: first is crossing sign on the lateral radiograph, second is the double contour sign, the shadow you see, and the supratrochlear spur, right? The fourth important aspect you need to evaluate is the sulcus angle to evaluate for the trochlear dysplasia. So the sulcus angle seen on the merchant view, normally it is 140 degree. If it is more than 140 degree, that is a shallow trochlea, which predisposes to acute recurrent patellar dislocation, right? So the trochlear dysplasia is one of the most important factors to be considered in recurrent patellar dislocation. So there is a classification for the same, de Jour's classification. So the first is, there is shallow trochlea. The first type is type A, is the angle is more than, the sulcus angle is more than 145 degree. That is shallow trochlea. The first is S, shallow trochlea. The second is the trochlea is flat or convex, as we saw over here. The trochlea is flat, or it is convex. That is the second type, right? The flat or convex trochlea, as you can see in the figure, that is the type B, right? The third is when there is medial facet hypoplasia. You see the classical double contour sign. Medial facet hypoplasia. That is the third type. And the fourth type is there is a elevation you see at the trochlear groove, which is which shows as the classical cliff sign. Okay, so that is type D. So the four types of DJOR classification: trochlear dysplasia, shallow, flat trochlea, shallow trochlea, flat trochlea, medial facet hypoplasia, and cliff sign, SFMC. That are the four types of DJOR's classification. You can see on MRI clearly the DJOR classification. There is shallow trochlea, there is shallow trochlea, there is flat trochlea, there is lateral convexity because of the medial femoral hypoplasia, in which you see a double contour sign, and fourth is the cliff. You see some elevation, at the trochlear groove, So shallow, flat, medial femoral hypoplasia, and the cliff sign, SFMC. Right? Now, for the radiological evaluation, why do you need a CT scan? To delineate the anatomy more clearly. Important factors to see on CT is the TT-TG distance, the distance between the trochlear groove and tibial tuberosity, the two perpendicular lines drawn from trochlear groove and tibial tubercle. If it is more than 20 mm, it is abnormal, which predisposes to patellar dislocation. Now, why do we need an MRI? Very important factor, very important radiological evaluation in the case of recurrent patellar dislocation is MRI. Why do we need MRI? To look for osteochondral fragment. To look for medial patellar facet. We need to look for lateral femoral condyle. And additionally, most important, we need to check the medial patellofemoral ligament tear. From which end? How much is the tear? What is the condition of the ligament right now? We can check the VMO and injury to medial retinaculum structure and medial soft tissue injury. So this is why we check for an MRI, right? So one of the case which I saw was a case of osteochondral fragment with patellar dislocation. So this was the MRI images of the same, in which, as you can classically see why MRI is important. You can sometimes it gets missed on X-rays. You can classically see a osteochondral fragment in the suprapatellar pouch, the suprapatellar region. You can see the osteochondral fragment classically in the. As you can see over here, the osteochondral fragment is seen. So you need to go for fixing the osteochondral fragment along with the repair of medial patellofemoral ligament, inframedial pole of patella, from where most commonly the osteochondral fragment comes up. Right? So that is the reason. This is the reason why getting a MRI done is very important, to look for the osteochondral fragment and the MPFL tear. So this is the MPFL tear from the femoral end. This is a combined MPFL tear from femoral and patellar, both the ends, right? So this is why these are the photos why getting a MRI done is important in evaluating a case of post-traumatic patellar dislocation, to look for the osteochondral fragment and to look for the MPFL tear, right? So we come to the last part or last section of our today's tutorial, and we are going to discuss the concept, the logical concept of how do we go for management and especially the operative fixation of a case of recurrent or a post-traumatic acute patellar dislocation, right? So the main concept of correcting the patellar dislocation is we need to align the extensor mechanism towards a more medial position. We need to align the quadriceps apparatus to more medial position, right? Some of the concept we need to understand is, if there is no skeletal abnormality, is just a plain post-traumatic MPFL ligament tear which has led to the patellar dislocation, which is causing multiple episodes of patellar dislocation, you straight away go for MPFL reconstruction or repair depending upon the condition. We already discussed, if it is from the femoral end or patellar end and the rest of the ligament is intact, you might go for a repair. But if the rest of the ligament is not good, or it is a it is a tear at multiple places, then you have to go for a MPFL reconstruction. Now, if there is a trochlear dysplasia and you have not evaluated and you straight away go for the fixation of osteochondral fragment and repair of MPFL, that is a nightmare, because The etiopathogenesis was not the osteochondral fragment, was not the trauma. The etiopathogenesis, the causative factor, was the trochlear dysplasia, which we discussed in the radiological evaluation. So that needs to be addressed. So we have to go for a trochleoplasty. So if there is a genu valgum which has led to a case of recurrent patellar dislocation, you should go for the correction of deformity as well, along with the fixation. Right? So if there is a high riding patella, you need to go for a distal transfer of the tibial tuberosity in skeletal mature patient, and in skeletal immature patient you need to go for a medial transposition of the patellar tendon. Right? So this was just the concept. We are going to discuss the named and important surgeries in the case of recurrent patellar dislocations. So the first surgery is the Hauser surgery. What do we do for repeated patellar dislocation? The tibial tubercle and the attached patellar tendon is transplanted distally and medially. As you can see on the X-ray, this was the previous site of the tibial tubercle, which has been transplanted distally and medially, and it has been fixed. So this is the current tibial tubercle. So this is the Hauser surgery, in which we go for distal and medial transfer of the tibial tubercle along with the attached patellar tendon. Now, next surgery is an important, very interesting surgery, is the Goldthwait-Roux surgery, in which the patellar tendon is split longitudinally, and the lateral half is medialized, is drawn medially, and is attached to the medial border. It is attached to the medial border of the tibia. So what our plan was, what our concept was to shift the extensor apparatus to more medially, so that we don't get again a episode of dislocation of patella. So this is Goldthwait-Roux surgery, in which patellar tendon is split longitudinally and the lateral half is drawn medially and attached to the inner border of tibia. Am I making sense? Now, the next surgery is very interesting surgery. It is the modified Elmslie-Trillat procedure, which is commonly performed, right? In which what do we do? We transfer the tibial tubercle, but the catch is we do not go for the distal part of the patellar tendon attachment is intact. We just go for a osteotomy over here. We just go for a osteotomy at the distal attachment site, and the osseous fragment is slided, is rolled medially in the gutter. A gutter is made over here, and the osseous fragment is rolled medially and fixed to get the desired medial shift, right? So what do we do in Elmslie-Trillat procedure? We transfer the tibial tubercle medially, but the catch is, as I said, the distal part of the patellar tendon, that which was manipulated in the previous surgery. The distal part of patellar tendon attachment is intact, and there is osteotomy which is done at the tibial tubercle, and the osseous fragment with the distal tibial attachment is rolled medially in the gutter and fixed to get the desired condition, right? So let's suppose if after the evaluation of the trochlear dysplasia, if the TT-TG distance is more than 20 mm, if it is 22 mm, right, which is leading to multiple episodes of recurrent patellar dislocation, after osteotomy, we slide the osseous fragment rolled medially. Approximately we medialize 10 mm to achieve 22 minus 10 to achieve the TT-TG distance of 12 mm. So this is how we plan operative fixation in a case of recurrent patellar dislocation, with the etiopathogenesis being of trochlear dysplasia. Right? Now, if there is a significant trochlear dysplasia, if the lateral femoral condyle is shallow, we have to go for a trochleoplasty. This is a very interesting surgery which is known as the LB's operation. So what do we do? This is the case. If a patient of recurrent patellar dislocation presents to you, and after radiological evaluation and X-rays and MRI, you find that the lateral femoral condyle is shallow, how do we go about for the operative fixation? The patella is laterally we go for a very interesting surgery. We go for anterior closing wedge osteotomy of patella. We go for anterior closing wedge osteotomy of patella, and we reconstruct. We put it over here. We reconstruct the lateral femoral condyle. We reconstruct the lateral femoral condyle with the bone graft which we have got from the anterior closing wedge osteotomy of patella. And once the lateral femoral condyle has been reconstructed, the trochlear groove has been reconstructed to a normal trochlear groove, the angles we want have been achieved. We fix the patella, we fix the trochlear groove, and we reconstruct the lateral femoral condyle. And this is how we prevent, this is how we go about for the trochleoplasty in LB's operation, and this is how we prevent recurrent patellar dislocation in the case of lateral femoral condyle dysplasia. Okay, so these were the important surgical named surgeries for cases of recurrent patellar dislocation. Definitely we go for the fixation of osteochondral fragment, generally an open fixation of the osteochondral fragment along with a MPFL reconstruction. This is the plan of management. But whenever there is some trochlear dysplasia, these are the important surgeries, these are the important factors you need to consider so that you get a good and better result. Okay, so this was the concept of acute and recurrent patellar dislocation. What are the etiopathogenic factors? We discussed logically how do we understand, radiologically evaluate the causative factors. We understood the management and surgical aspect in detail logically, and the named important surgeries. So ladies, that was all about patellar dislocation. This is Dr. Mihir Tejura signing off with patellar dislocation inside out simplified for you. Hope it helps. Thank you so much, guys.